So we will have a bit of a group Q&A. So while Adrian and Tracy join us, I think I'll start with a question for you, Cathy, while everyone is getting organized. How do you think we get primary care to feel more comfortable taking ownership of managing pain?
Yeah, it's an excellent question that we spend a lot of time thinking, and I certainly do. I spend a lot of thinking, how do we implement change? How do we take ownership of this? And I keep coming back to that agreement in principle. It is a powerful document. It's committing us to, take a look at how we attach patients that have complexity. And it doesn't have to be just with chronic pain. And how do we implement that? But I think what happens in primary care is that we always feel like everything gets downloaded to us without a resource. And that's where the mentorship network comes in as, okay, we've got this mentorship network. Let's develop the resources and support each other, because we know there's no new money. There's not going to be a big transfer of resource from Alberta Health Services and nursing and interdisciplinary teams. So how do we support each other and do the best we can with the resources that exist, and what resources and gaps do we need? I think that's important. The other thing, I know Tracy's on the call, it's been so helpful to hear from our patients to talk about, this is the gap, this is what you guys need. From a patient's journey, because often we think we know what patients want, but we don't ask. And so I think some of the sessions that we've had where patients go, you need to slow down, you need to listen to us, you need to break up the appointment, really basic stuff, but that's been super successful. I think we need to start at grassroots, and then we need to support our PCNs. And the other thing, we need to not work in competition. We're not in competition with pharmacists. We should be working together, and we need to understand each other's role and support each other. So I'm hoping that through this network and analyzing the network to see, does it make a difference? It's going to, be helpful in the implementation.
Tracy, do you have anything to add there?
Well, I agree that there's a lot of work left to do, and I agree that we need to have patient voices in there. I think the agreement in principle gives us as patients some hope. When we reached out to healthcare professionals, we reached out with a problem, and that was the experience that patients were having. That was the bias we were facing, the inability to find doctors to take over a care, and they responded. This begins the conversations we need to have within our communities, within medical practices, and across the province, so that we can identify and improve the care that patients need.
Cathy, do you, and perhaps Adrian as well, are physicians receptive if you come in with a list of, I've got 5 questions or 5 things I want to ask you? Do you think, oh no, or do you think, oh yay, 5 and 1? Cross it off, 2, cross it off. What's the reception for that?
Yeah, it really depends on the physician. So personally, I love it because it organizes my time. And I think that it's helpful to organize those things, and certainly in residency training. So I do come from a training, session or a training site. We talk about, okay, what are the priorities if someone comes in with a list and you can't realistically address it? But I think the key things that Tracy and Ryan have taught me is, pick those priorities, but get the plan and make sure that you're following up. Like, don't go, come back if it doesn't work. And then the other key thing is that crisis management plan. Make sure that if things are going south, don't wait the 2 weeks or a month or end up in emerged. Like, have a plan so that you can get in and deal with it again. And I think most patients are happy to have not all those concerns dealt with at once, but that there's at least a plan to deal with them one by one. That would be my experience.
Okay. A question for Adrian. Someone wanted to know if there's a place for patients to learn more about polyvagal theory so they can use the ideas to self-regulate. So whether there's books or courses or YouTube videos that you might be able to recommend. And we can put them in the chat too if that comes up.
Yes, there are. It's starting to come together. There's a lot of different routes to all of this in terms of who's weighed in on it, but there's some resources that are starting to become more practical. And when we do at the end of this session, when I do the movement, the little 5 minutes at the end, you'll have a chance to just experience it a little bit yourself. And hopefully that'll inspire you a little bit to try it with, you could try it with one of your family members, maybe first, or a friend, and then try it with your patients. Doing it with them is more effective than just telling them about it. And I wish there was a bit more user-friendly language, because the word polyvagal theory doesn't really sound very
not sexy at all. No.
Or like it sounds like a theory. Like, no, it's this is so practical. I think we probably need to reframe that, or yeah.
Right.
Yeah.
Well, I love thinking about something that Tracy was saying, to start, and then you build upon it. But just thinking, if patients come in with anxiety and stress, and that means the healthcare providers feel that stress and are stressed themselves, like how beautiful would it be if you together did a little bit of a breathing exercise for a minute or two to calm both of your nervous systems down, right? I just think that would be really useful.
Yeah, and another thing that I do is I just have most of my patients have their phone with them. If not, I can show them on my phone, but I just get them to Google or search window of tolerance and images, and there's right away they'll catch 4 or 5 of those pictures with the 3 stripes in it, and then you can talk through, okay, when you're feeling really hyper aroused, here's some things that we can help you shift, and when you're hypo aroused and really disconnected, here's some things that would be helpful.
Yeah, I'd be curious to know if there's, I sort of feel like people would watch a YouTube video rather than take a course or read a book on it. That would be really useful to think about. The other thing Cathy talked about was the 1-pager education summary of, an in-service, probably geared toward healthcare providers, but certainly I think if that was written in collaboration with Tracy's group, that it'd be really great to develop a one on polyvagal therapy and theory, and maybe come up with a little bit more catchy of a name, or even break it down or something like that. But the 1-pager seems really good, and then we could disseminate that with Tracy's organization, right? So
yeah, it'd be great to have that patient facing plus provider facing. We'll have to connect, Adrian. I don't know exactly. Yeah, our communications people are on here, but we have a person that does a lot of our graphics, so we'll connect.
Right. Well, and I'd love to suggest that you use Tracy in there as well, just because I think it'd be good to have the patient perspective. She can disseminate from her end, Tracy, do you find that most people have a computer? Because I'm just wondering about the whole virtual care and how much is the problem. And maybe all of you might want to comment on this, but I'll get Tracy to if we're interested in new delivery of healthcare, any ideas for connecting virtually with those that don't have access to a computer, and so that we don't leave those folks behind?
Well, we were a little worried about that, but one of the things that we discovered pretty quickly is if they don't have a computer, it's probably because they have a smartphone. And a smartphone gives you the ability to do that as well. And apparently a couple of our patients were telling us that as long as your game system has the ability to access the internet with a Chrome browser, or your TV does, you have the ability to also, say, do a Zoom meeting or a Google Meet to access virtual care as well. So the ability to access it is there. We had some patients that struggled with how to access it, but we found that very quickly they learned with a little bit of support.
Yeah. Well, and certainly, I mean, I think of my in-laws and my father, both 87, you know, and he's got 2 or 3 iPads. And like, I think we underestimate people's technology savvy. Maybe they're not Gen Y for sure, but, or X, I think it is, sorry. I've got the gens mixed up. Supercomputer savvy, but I think that they definitely can use. So. Okay, the last question, because I know we're a little bit over the Q&A part, but this is really interesting. I'm going to target it at Adrian, but I'd kind of like your feedback on it as well, Tracy. When we think of something that Neil said in his presentation, and the question is functionality a better goal than less pain, and or a more realistic goal? And then how would the clinician best convey this idea to the patient? And also, I'd be curious to know from Tracy's point of view, is like, how would that be received, you know? And how do you try to language this so that it's not someone saying, you know, your pain isn't important? So maybe Adrian, you can start, and then Tracy, you can add.
Sure, and I'll be interested in your reflections, Tracy, as well. So when I'm with patients, this is a huge thing, because pain, you can chase it all over the map, and it's very elusive. And as we know, I mean, if it was easy, we wouldn't be having in this conversation today. So pain is very multidimensional. It's elusive, as I said. It tends to be something where people, that is what gets people's attention, for better or for worse. And fair enough, it's really got to be in the conversation. So I usually start with their pain, and I have them explain and describe it a bit more. And then I start to talk about the impact in a few areas of their life, how it's affected them. And then that's how I get into the conversation and saying, okay, so we really have 2 things going on. We have pain over here, and we have function over here. They're not really disconnected, but we'll think about them slightly separately. Mm-hmm. And mm-hmm. If we were to reduce your pain, hopefully that would make you feel like you had a higher quality of life. What about if we increased your function, if you were able to do some things that were meaningful to you? And so rather than tell them, I'm sort of using a bit more of an inquiring voice as I'm bringing up this conversation. And I watch their eyes, and they seem to be going, oh, okay, so maybe this is something to think about. And if, there are people who are kind of the early adopters, and they're going, oh yeah, I've been thinking that already. And I get that my pain is a problem, but really what I want is to be able to do this, this, and this. Other people, it takes quite a bit more. And sometimes I can find something that's really meaningful to them, maybe being able to just hang out with their grandchildren a little longer, or go for a walk with their dog that they haven't been able to do. And I guess lastly, what I tend to do is also say how frequently it is, and this actually mirrors the talk that I gave, how frequently we can go into what we call boom and bust, where we overdo it because we have a bit more energy, we have a bit more capacity today, and then we're down for 3 to 5 or 10 days or however long. And so being able to shave off a bit of those overambitious days, mm-hmm. be able to invest that in days when we haven't overdone it, so we can have more capacity on those other days.
Mm-hmm.
Well, I think that there's a pretty good chance that if you say something to the effect of, well, we're going to focus on your function because that's more important, immediately the patient's going to take it badly. And from there on, that appointment's going downhill fast. I think it's important that we address both. If my pain is a 7 or 8 out of 10, and you start talking about how far I can walk or whether or not I can play with the grandkids, that is a secondary concern at that time in that place. But I agree that once we start to get a handle on that, we get it down to a more reasonable place, we do address them as separate entities, and we work to improve both. I think it's also important that in the relationship that we have with our doctor, there's the ability to have honest communication. And one of the things that needs to happen there is that the doctor needs to be able to help the patient understand that improving function does have an impact on pain levels for most people. And so if we ignore this, if we ignore the function and just focus on pain medication, we won't be doing the best job for you. If you want the smallest amount of pain, in the best quality of life, we have to address both.
Excellent. Can I just add one more thing? Because of the neuroplasticity of our brain, the more, whatever we focus on and whatever becomes the most important or salient thing, it actually starts taking up more real estate in our cortical system. So if we lose some of our vision and we have to rely on hearing, then our auditory cortex will borrow from our visual cortex to enhance its ability to problem solve and to find our way through things. Much also, if we overfocus on pain, and I'm not saying this to say it in this way to your patients, but the more that becomes the thing, the more we actually are reducing our capacity to have our brain do other things and more often functional things. So there are definitely situations where people have chosen to change what their focus is. And a little bit like my story about Honduras, but choose to change something because our brain is very powerful, and it will start to add more real estate, or that is more dedication of certain real estate to things that we tell it are more important. So
I think the way that we discuss that also is important. So for me, the aha moment was when a doctor explained to me that instead of sitting on the couch and worrying whether or not I move, it will increase my pain. And then the pain will get to be too much and I have nothing I can do about it. And then I can't sleep. And my entire day revolves around that thought, that fear, and that worry. And it's real. It's a real worry. It's a real concern, but it centers around that. Whereas when I started working on function, I started seeing it as if I focus on doing these extra 10 steps, and literally in my world, that's what it was, the extra 10 steps, then my brain didn't panic about what came next. And I discovered that extra 10 steps led to another extra 10 steps. And I was able to build up and do more while managing my pain.
Beautiful.
Yeah, that's a brilliant way to end there. Thank you to the speakers for this morning's grouping. This has just been a really fruitful discussion, and I know we're running slightly over, but I kind of didn't want to end this abruptly because it was so good.